Okay, hello, good evening. Today we are going to discuss together a very important topic about emergency and trauma management, eMRCS question bank. Today it's about 100 questions, maybe less, a little bit less. So we'll take half the session today and then we will continue later the other half or the next half of the session 2 or 3 days later. Okay, maybe tomorrow also. Okay, so let's start now with Dr. Farah. Okay, as we used every time, Dr. Farah. Okay, تفضلي.
A 45-year-old man is admitted after his clothing caught fire. He suffers a full-thickness circumferential burn to his lower thigh. He complains of increasing pain in the lower leg, and on examination there is paresthesias and severe pain in the lower leg. Foot pulses are normal. What's the most likely explanation? A. DVT, compartment syndrome, rhabdomyolysis, spreading synergistic spreading infection, nerve injury. B. Compartment syndrome.
Okay, anyone has different answer? You can answer, by the way, in the chat. So if one has confused or a problem with any answer, we can correct or explain it. Okay, so all agree about compartment syndrome. Yes, exactly. Here is a man with a full thickness circumferential burn to his lower thigh, and the cardinal sign of compartment syndrome, which is pain, paresthesia, and sometimes impaired movement or decreased movement pain sometimes, and pain when stretching the compartment, but pulse is still normal. Okay, don't confuse with the pulse, because pulse is the last sign to disappear in compartment syndrome, and when pulse disappear, it's a very bad prognostic sign. So don't wait for absent pulse for compartment syndrome. Don't wait for absent pulse for compartment syndrome. A very important topic in pathology and in critical care in part B. When he asks you what is the last sign and when he asks you about the signs and clinical picture of compartment syndrome, you have to mention pulse, the last point, and you just have to mention it is the last sign to disappear, because of it's a very bad prognostic sign if disappear. But the problem starts with severe pain, paresthesia, this is sensory impairment, and also motor impairment, followed by absent pulse. Is it clear about compartment syndrome?
Yes.
Clear. Okay. Simply, this is what is needed from you in compartment syndrome. What's the treatment for this patient? Before we go for the next question, what is the best or the most next step treatment for this patient?
Fasciotomy.
Fasciotomy, immediate fasciotomy, emergency, immediate fasciotomy. You have to tell this emergency in the exam. You have to be accurate in your answer in part B, because every word you say, it is marked in the sheet mark. Immediate fasciotomy, immediate fasciotomy. Okay? Okay. Next question, Dr. Mawahib.
25-year-old man is shot in the abdomen and is transferred to the operating theater following arrival in the emergency department. As he is unable unstable, and the first scan is positive. At operation, there is a extensive laceration to the right lobe of the liver and the involvement of inferior vena cava. There is massive hemorrhage. What is the most appropriate approach to blood component therapy? Use factor VIII, concentrated early, avoid use of a negative blood, transfuse packed cell and platelet in the fixed ratio 1:1:1, transfuse packed cell and FFP in the fixed ratio of 4:1, perform a goal-directed transfusion based on the HB platelet and TEG studies. C. Transfuse packed cell, FFP, and platelet in fixed ratio 1:1:1. There is no sound.
There is no sound, Dr. John.
Okay, sorry. Now, good?
Yes,
Okay.
good. Yeah.
Okay. Here's what he wants to tell you. That in massive blood transfusion, in massive hemorrhage or trauma, the protocol of blood transfusion is packed RBCs, rich frozen plasma, and platelet at the same ratio, 1:1:1. Okay, this is the massive protocol for massive blood transfusion. This is very important. This is very important to know. He wants you to know this point. And by the way, this question is very common in exam, very common in recalls, very common in exam, very common in recall, by the same idea and by the same scenario. Okay, the massive blood transfusion ratio is 1:1:1. Okay, I hope that's clear. Okay, Dr. Ahmed, you want to ask about anything?
Yes, I just want to ask why not avoid use of O negative blood.
Avoid use O negative blood.
We give actually O negative blood in this if it is not available because we don't have time for cross matching.
No, sometimes you use negative blood. Sometimes
Exactly.
you have to use negative blood.
Yes.
Yes. What is the problem here?
He said avoid use of O negative blood. It is yeah. Yes, we can use it. Yes, I understand. So
yes, you can in massive trauma and you want to save the patient. You can use O blood, and you have some protocols. Sometimes you
yes.
Sometimes you you have to use, and you have give precautions. Sometimes you give corticosteroids. You give you make total blood transfusion and exchange blood of the patient. But
yes,
here, this is he wants to ask about the protocol. No, it like this. He wants to ask about the protocol of blood transfusion. What is meant by massive blood transfusion? It's very common exam in part B. Anyone has any definition for this?
But I think massive blood transfusion is giving of 10 units of blood.
It is the volume transfused, which is more than the total volume of the patient.
Yeah, it is whole blood transfusion.
Within?
Whole blood.
Within 24 hours.
Within 24 hours. You have to tell complete definition. Okay?
More than 2 units in 1 hour, or more than...
Sorry?
More than 2 units in 1 hour, or more than total blood volume in 24 hours.
More than the total within 24 hours, or more than half within 1 hour. Okay, I think it's
yes, thank you.
I think it's here. Yes, here is the definition. trauma patient, we need massive transfusion. In the second line, massive transfusion is defined as a replacement of the patient total blood volume in less than 24 hours or as acute administration of more than half the patient's estimated blood volume per hour. Okay?
Yeah.
Okay, this is definition. These two definitions you have to put in mind because it's a very common also question in part B, critical care. Okay, next question, Dr. Ghada.
A 19-year-old man is stabbed in the chest at a nightclub. He develops a cardiac arrest in casualty following attempted transfer to the CT scanning room. What's the most appropriate cause of course of action? Immediate CT scan with ongoing CPR, echocardiography, thoracotomy, pericardiocentesis, or chest ultrasound. Cardiac arrest, there must be CPR. The first option. But there is a cardiac arrest. We might same mistake as usual. There's a stab injury, either CPR or something else. I'm not sure. Okay, there's a stab injury. Either CPR or thoracotomy. I'm confusing also. Because of stab injury, and there's cardiac arrest.
Dr. Rami, there is no voice. We can't hear you.
Sorry, I didn't see anything. I'm just reading. Answers. So we have C, 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 and then some change it to D, 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 and one choose A, like Dr. Ghada. What do you expect in this patient? He has a penetrating chest trauma and a cardiac arrest. We prefer CPR. We prefer CPR for medical patient, not any penetrating chest trauma or accident or any trauma. This patient mostly have one of two problems: even massive bleeding, which may cardiac arrest, and he's a young patient, even in the chest or in the pericardium. And both of them, whatever you will do, you have to do CPR. You have to do a thoracotomy. Again, this patient, your aim, this patient to be alive. Okay, yes. What's expected that this patient died from? This patient died from massive acute hemorrhage, whatever, in the chest or in the heart. Okay?
Yes.
So the only solution for this patient that you have to do a thoracotomy. By the way, I just knew a story, but it's about 10 years ago, about one doctor who did thoracotomy in the ambulance. Okay, patient arrested, and he know by diagnosis that he has pericardial bleeding, effusion, cardiac tamponade. What he did by any maneuver, I can't remember the story, and he just opened and evacuated the blood and start pumping the heart with his hand. This is what's called like internal CPR, not external CPR. He started with the ambu, with one hand or the assistant hand, and he started to make CPR by holding the heart in his hand and doing pumping by his hand till he arrives to the hospital. I can't remember the full story, but this is a true story. Already he died. Already he died at the scene of accident and gasping, and then died. What he did? Okay, if you wait till you go to the hospital, he will die. If you started just normal CPR and he has a cardiac tamponade or chest thoracic bleeding, he will die. There will not be any response. But what he did, he just evacuated the blood and started to put his by one hand, hold the heart and start pumping the heart with his hand. Okay, so thoracotomy here is very important. Inpatient immediately die after a stab or penetrating wound in his chest. So there is no time for CPR or CT or something like this. Okay? Clear about thoracotomy?
Yes.
He already died. The patient arrested.
Yes.
So thoracotomy can save the patient. Any other option will not save the patient. Will not enough to save the patient. Okay.
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 Can I ask a question, Dr. Ahmed?
Okay, Dr. Ahmed, fadal.
Yes. Why not pericardiocentesis? Is maybe cardiac tamponade may.
Pericardiocentesis is done sometimes blindly and sometimes under ultrasonic guide. You have no time for all of this, and it aspirates a little blood, little blood. But thoracotomy, it's at once. In an expert surgeon, thoracotomy can be done at once.
Yes.
Okay. 2 years ago, 3 years ago, I was working in a hospital in Egypt, and we don't have any cardiothoracic surgeon in hospital. And sometimes every 2-3 months, a cardiothoracic surgeon come from one university. In university, they make like a contract. He come for 2 weeks covering just to follow up some cases, but elective cases, not emergent cases. Okay, so we can stay 3 months without any cardiothoracic surgeon, and then they inform us, okay, there's a cardiothoracic surgeon will come from some university to follow up some cases. You have to prepare case for him for 2 weeks, just for fun, okay? And what happened exactly is that a patient, young age patient, coming to the ER, and he has a stab wound in the center of his chest. Okay, this doctor was just arriving to the hospital with his bag, and he asking about the entrance of the hospital is the ER, and he just putting his bag and going to ask someone of the security, where is the where can I go for my place to stay, or the doctor's rooms and something like this. And he found this patient entering in the ER, and he just putting his hand on his chest and bloody. What he did, he just left his bag and he ran away and to see the patient. And he said, please once go to the, what is your operation room? I need to make thoracotomy for this patient. In the first minute he entered the hospital, he took the patient, they took him, and they took the doctor without any investigation, without any nothing. He went up to the operation room, the OR, and he did thoracotomy, and he found a ventricular tear. A ventricular tear. And this patient was sutured, and this patient is alive. Okay. So he's so lucky, the patient is so lucky. And by the way, we haven't seen within about 4 or 5 years working in this hospital any cardiac tamponade case or the same case. We just saw this case one time. And at the time, the doctor just arrived and he followed up this patient his 2 weeks till he discharged the patient before he left. The patient has a cardiac, left ventricular tear, and he just put his finger in the tear till he sutures the tear and they close the pericardium, and the patient is alive. So that's, I can remember by this case. I can remember by this case, if any patient just arrested and you doubt that he has massive chest or a cardiac or cardiothoracic bleeding, you have to do thoracotomy at once. Okay?
Yes.
Okay. Nice story just to remember about this. Okay, next question, Dr. Ali.
Yeah. 76 years old woman with a body weight of 50 kilograms undergoing an excision of lipoma from her forehead. It is the first time the senior house officer has performed the procedure. He administered 30 ml of 2% lignocaine to the area. The procedure is complicated by bleeding and the patient experienced discomfort. Further 10 ml of the same anesthetic formulation is then administered. Over the following 5 minutes, the patient complained of tinnitus and become drowsy. Which of the drug is listed below should be administered? Yeah, timazepam, lorazepam, naloxone, intralipid to 20%, sodium bicarbonate 20%. Lipoma forehead here. Yeah, this is the toxicity of lignocaine. Yeah, the procedure complicated, bleeding and patient experienced discomfort and drowsy and tinnitus. Yeah, I think naloxone, no. I think we give intralipid 20%.
Yes, it is.
Okay, intralipid 20%.
Yeah.
Dr. Dr. Mumtaz. I don't know the third name. I can't understand the language. Okay.
Yeah.
Exactly. This is a lignocaine toxicity.
Yeah.
Okay. This is a lignocaine toxicity.
Just sodium channel blocker.
Exactly. He wants to know, by the way, this is also a common question in the calls. The antidote for lignocaine toxicity is that you give IV infusion of interlipid 20%. Okay.
Yeah.
Interlipid 20%. And we said before that questions about pharmacology, not so many in the exam, maybe less than 10, maybe less than 10. So it is not confusing, and we just know it by itself. Yeah. Sorry.
I have a question. Sorry, I have a question. What is the meaning of the intralipid? Why they don't say lipid or something?
This is some sort of infusion called intralipid.
Intralipid. Why they don't say lipid intravenous, for example, or?
It's named. It's a name like
Hartmann
solution,
right? Yeah. Oh,
glucose solution. This is a name. Saline, Hartmann, interlipid. Interlipid. This is one, and even it's something like we use sometimes in TPN.
Okay.
Interlipid. Okay. The name. It's a name. Okay, Dr. Ahmed, تفضل.
Yes, please. I wanted to ask that I know that lidocaine may cause methemoglobinemia, and methemoglobinemia has different treatment than interlipid. I don't know if I'm confused or not.
Maybe he don't want all these details from you.
Yeah.
Yani, okay, sometimes some information, but don't confuse yourself by information why we give this. Maybe ask it from you for you in part B, and even part B, they just ask about the most important about local anesthetics. You know, you have to know the name, you have to know the dose, and you have to know the toxicity. Okay?
Yes.
This is very important in part A and part B. Part B, you have a session in procedure skills about local anesthetics. He will ask you about the name, types of local anesthetics, mechanism of action, and also he will ask you about the toxicity or the maximum dose of each one. I think we discussed about it, or still not, and we'll discuss it in the
25
operative
ml.
technique. It's about 20. No, lignocaine, it's about the 20.
25.
Mainly for 1%.
5.
For 1%. 25 what?
25 ml.
Lignocaine toxicity. It is the maximum dose for lignocaine 1% is 20.
5.
21 exactly. 21 exactly. I can remember it's 21 because you give just a second. Yes, this is exactly. Yes, lignocaine 3 milligram without adrenaline, and 7 milligram with adrenaline. 3 milligram if it is 1%. If it is 1%, so you will give just a minute. You will give, if it's 1%, so it will be 10 milligram per milli, and you give maximum for 3 milligram, yes, for 70 kilo, so you will give 210 milligram, so it will be 21 ml. This is the maximum dose. Okay. This is the maximum dose. We will study it again, I think. Just a minute, please. Okay. By the way, you have to know that this one also, prelocaine toxicity, we give methylene blue. So interlipid 20% for lignocaine toxicity. Okay. But for prelocaine toxicity, we give methylene blue.
Yeah.
Just know the name, okay? I think here 10 ml of lignocaine 1% is 100 milligram of drug. So 1 ml is 10 milligrams, so we give 21. This is the maximum dose, by the way, 21 ml. And generally, we say 20 ml is the maximum dose. And even in part B, if you say 20 ml, it will be considered right, not exactly 21. Okay, next question.
Me, Ahmed Reza.
said Dr. Ali, then Dr. Ahmed Reda, يتفضل.
Yes. A 22-year-old man is admitted with severe recurrent chest pain and recurrent episodes of dysphagia. These occur sporadically and often resolve spontaneously. On examination, there are no physical abnormalities, and the patient seems well, with the most likely explanation: chest pain and recurrent episodes of dysphagia. Gastroesophageal reflux, perhaps syndrome, esophageal cancer, echolasia, and pulmonary embolus. I think chest pain and recurrent episodes of dysphagia.
All these are surgical cause of chest pain.
Yeah.
But the patient resolves spontaneously.
Yes.
So you have to exclude some and maintain some, and then see the difference between both of them.
I think it is maybe echolasia.
Okay.
Because
Many
gastroesophageal
said it
reflux,
is reflex.
not reflux doesn't cause dysphagia, I think.
So most of here said A. Dr. Ali D. Echolasia. So what you expect? رأي الجمهور.
I think echolasia. I don't know.
You think echolasia?
Yes, echolasia.
Dr. هذا echolasia. Dr. Siraj.
I think it's B.
Dr. Siraj, I think is B. Burhave
It is
syndrome.
B.
It is can resolve spontaneously.
I'm thinking because really, I'm not expecting echolasia to resolve spontaneously because this is symptoms that I expect to continue.
What's echolasia? This is a disorder in the lower esophageal sphincter.
Yeah,
Some spasm, and this spasm sometimes when it is full enough amount of food or fluid above, it can cause the release of this spasm by pressure. Okay, let us think together about this question and how I think about this question in the exam. Okay, this patient has severe retrosternal pain and has resolved spontaneously. Let's go for the option. Can gastroesophageal reflux cause severe retrosternal pain? Not common. Can't cause severe. It just have discomfort, some burning, something like this. But doesn't make severe retrosternal pain and then spontaneously resolve. If you have to take antacid, you have to take a proton pump, you have to take something like this to resolve it. But this is something that has a pain and then the pain released spontaneously. So some collected fluid above the sphincter, and when it is overcomes the spasm, the lower esophageal sphincter opened and then evacuate everything and then spasm again. Again, Burhave syndrome, no, it will not. This is a esophageal tear, will not resolve spontaneously. Esophageal cancer, no, will not resolve. Echolasia, yes, maybe, why not? Pulmonary embolism will not spontaneously resolve. Okay. So echolasia is the most common and most suitable answer for this question. Okay.
Yes.
I think clear. This is the way how to think about. Okay. Next question, Doctor. Dr. Mahmoud.
Okay.
Dr. Mahmoud, I think.
Can I read
Dr.
it?
Sira, you want? Okay,
Yeah.
so see Dr. Mahmoud turn and then you can go. Dr. Sira after him.
Okay.
Dr. Mahmoud, Samah, open your mic.
Okay, I just joined,
Okay.
but I can read it. Okay.
If you don't want to
Okay,
start now, you can
it.
wait. No,
I can go with
can
it.
go. Okay.
Yeah.
Sure.
A 27-year-old man is involved in a road traffic accident. He is seen in the emergency department with chest pain. Clinical examination is essential, unremarkable, and he is discharged. He subsequently is found dead at home. What's the most likely underlying injury? Tracheobronchial tree injury, traumatic aortic disruption, cardiac laceration, diaphragmatic rupture, rupture of the esophagus. We had chest pain, unremarkable and discharged.
It could be aortic disruption. B.
Okay, just waiting for him to answer, and then give him just a chance to answer.
I'm confused with B and C, traumatic aortic disruption and cardiac laceration.
Okay, let's see the answers. B, E, diaphragmatic, rupture of esophagus. B, traumatic aortic. B, C, cardiac laceration. B, traumatic. So I think we have all the answers. Okay, let's discuss the answer together. If this patient, he just arrived to the hospital after a road traffic accident and with chest pain, clinical examination, so the patient was almost normal at examination at hospital, and he went home and he died at home. There is a big or a long time between the accident and time of death, okay? In between, he is normal. In between, he is normal. What of these injuries that make the patient die and after a few hours of the accident? Okay, let's take it from down. Rupture esophagus. Is examination in the hospital for a patient with rupture esophagus will be unremarkable? No vomiting, no hematemesis? I don't think so. And even if it's a small rupture, he will not die at home from this rupture. He will go for mediastinitis or something like that. Even if it is a large or a major trauma, he will have hematemesis and signs of mediastinal emphysema and surgical emphysema of the chest or something like this, or it is a minor injury, he will not die at home. Diaphragmatic rupture, the same like esophagus. The same like esophagus. Examination will be remarkable, and may the patient have pneumothorax or something like this from rupture of diaphragm, or intestinal sounds in the chest, or difficult breathing and something like that. Cardiac laceration.
Immediate cardiac arrest.
Immediate. The patient will die at the site of the scene. Cardiac laceration, and this is, by the way, cardiac laceration and the proximal aortic disruption, the patient mostly will die at the site of accident. Cardiac laceration or proximal aortic disruption, the patient will die at once. The only trauma that the patient can resist few hours is the distal aortic disruption. Distal aortic disruption means distal to the
three main branches of the aortic arch.
No.
You mean the
ligamentum arteriosus.
You mean
distal to the ligamentum arteriosus.
Yeah.
Sorry.
You mean descending aorta? We have two parts of aorta.
Arch. After the ligament. After the we make it proximal and distal according to the ligamentum arteriosus.
Yeah.
Okay. So most deceleration injury, most common that happen in patient with chest trauma happens distal to the ligamentum arteriosum. Okay. Most injuries happen in the aorta, in the aortic disruption or aortic laceration, happen distal to the ligament, in the end of the arch and descending aorta. Proximally is the next most common. And how to differentiate? Mostly the patient with proximal will die, and both of them, by the way, make widening of the mediastinum. Both of them make widening of the mediastinum. And it was a confusing question, I think, in Recall 2020. I think in January 2020, or the previous exam, maybe in September 2019, this question came. It was confusing, is because he gets the two answers. It's the proximal or distal aortic disruption. Most common is the distal. Proximal, the patient mostly will die at the scene, and distal, the patient will arrive hospital and die at hospital or at home. Cardiac laceration, he will die at once. Tracheobronchial tree injury will not come with this scenario. Tracheobronchial tree injury, the patient sure will have a remarkable examination, and it is not the cause that the patient can go home and die at home.
It came
is it clear how? Sorry?
It came in 2020.
2020, yes, as I remember in 2020, yeah?
Mhm.
Okay, the answer is, we will face this question here. Okay. So it's clear about this question here?
Yeah, yes, it means distal to the ligamentum arteriosum between the arch and the descending, right?
Yes.
I think
It is in the arch. It is in the arch, ligament arteriosum.
Yeah.
Immediately in the arch. Okay. Okay, Dr. Daffer ready?
Yeah.
Then Dr. Sarah. Okay, Dr. Daffer, تفضل. Okay, Dr. Daffer, then Dr. Sarah after Dr. Daffer, okay?
Okay.
I'm ready.
Dr. Daffer, تفضل.
The screen, yeah, okay. A 10 years old child admitted with a severe 30% burn follow a house fire. After wound cleaning and dressing, he is admitted to the critical care. When they follow skin graft, he's become tachycardia, hypotensive, he's vomiting twice with the show evidence of hematemesis. What is the most likely? Disseminated intravascular coagulation, ulcer, curling ulcer, yes, true. Delivery lesion and miliary hearing. So it is C.
I think someone has noise background, please.
Yeah.
Anyone, please, Dr. Ahmed, I'll mute you. I need one just open his mic, not to have any noise background, please. And then whose turn, just open his mic.
Okay.
Okay, all chose C. Curling ulcer, I think it's an easy question. This is a stress ulcer, which what happens with burns for any patient.
Yeah.
Curling ulcer. Okay.
Okay.
Okay, next question, Dr. Sarah. تفضلي.
Okay,
start.
A 20-year-old Indian woman who is 18 weeks pregnant presented with increasing shortness of breath, chest pain, and coughing. Clear sputum. She is apyrexia. Blood pressure is 140 on 88 millimeter mercury. Heart rate is 130 beats per minute, and then saturation is 94% of 15 liters of oxygen. On examination, there is mid-diastolic murmur. There are bibasal crepitations and then mild pedal edema. She suddenly deteriorates and has a respiratory arrest. Her chest X-ray shows a white out of both of her lungs. What is the most likely explanation? Oh, shortness of breath. You have, I'm not too sure, diastolic murmur. It could possibly be possibly acute exacerbation asthma, but you have B is pulmonary embolism, mitral regurgitations, mitral valve stenosis, and aortic dissection. I'm not really sure what the answer might be. Increasing shortness of breath. B. Oh, okay. Let's go to chest pyrexia and blood pressure. Yeah, it could be mitral valve mitral regurgitation.
Mitral
I'll go with,
regurgitation.
let me see. I think
You
so.
go with C, and we have many go D.
Okay.
Dr. Yasser Rigar. Again, he says stenosis. 3D. Who went for stenosis? Does stenosis give us a mid-diastolic murmur? I think we explained about this before,
Yes.
about murmurs. He mentioned here a murmur. He just want to tell you, I need, what is a murmur? All these questions, by the way, you can abbreviate it in patient with a mid-diastolic murmur. What is the most common diagnosis?
Okay.
Dr. Abdul Qadir, you want to ask about anything?
Is it a mitral valve related any disease kind like mitral valve stenosis? As mitral valve stenosis has two type of murmur, like mid-diastolic rumbling murmur and also the accentuation of the heart sound. So it can be mitral valve stenosis.
So you choose stenosis.
I have comment also about mid-late. We have early diastolic and we have mid-late diastolic. Early diastolic happen in aortic and pulmonary regurg, while mid-late diastolic happen in tricuspid stenosis and mitral stenosis.
Okay.
So I think we are going with the mitral stenosis. We can exclude pulmonary embolism because in pulmonary embolism, you have low PCO2 and low PO2. So both of them are low. I mean, the saturation of oxygen and saturation of CO2. And you have here, in this case, normal saturation of oxygen. So you can exclude pulmonary embolism in this case.
It's not so normal, but the patient is taking 15 liter and he's still 94. Should normally, but the patient has chest problems, basal crepitation and chest X-ray whitening. So the patient has a problem in gas exchange. You go for stenosis. Dr. Khalifa.
Yes, I also go. I'm in the idea with mitral valve stenosis, but the scenario is also showing features of heart failure. Heart failure with pulmonary edema.
Exactly. So here is all the questions. Sometimes you find in the exam very long scenario. The patient is going, has a very car accident, and he went to hospital and he resuscitated, and then his blood pressure is high, then becoming low, then the patient started to walk, and then he can't walk, so he have an ankle problem. What is the most common bone fractured? Okay, so he just want here, what's all the story? He just want a pregnant woman from a different area or away area or a common area with rheumatic heart, like Indian places or sometimes many countries other than India. And he just want, this is a very common problem that the patient has rheumatic heart or mitral valve problem. So this patient have a mitral stenosis. I just want to remind you, diastolic murmur, be simply, diastolic murmur, go with the anyone has a problem with murmurs? I can briefly, but it is not our issue today. But as I explained before, Dr. Ibtihal. I'll say it rapidly, and when you revise your the video, you can understand again. I'll make it. We are surgeons. So overhead. Okay. Doctor. And simply, I have did this once before. This is the heart. Okay. I have this one coming here and this coming here. I have blood coming here with diastole. Okay, when this happened diastole, I have blood coming through the mitral, whatever here, the mitral or the during diastole. I have blood coming through the tricuspid or mitral valve. Okay, this is the blood coming through the mitral or tricuspid valve. If during diastole I heard a murmur, and by the way, should be here competent valve, whatever the pulmonary or aortic valve is competent. So during diastole, the only valve open should be this and this. If I heard any murmur, so there is a problem with these valves, which is stenosis, because blood is coming from here to here. So I hear a murmur, so it is stenosis. The blood can't go simply and freely and smoothly. So it is a stenotic murmur, okay? And I hear it, he will tell you in the fifth right intercostal, left intercostal space, or in the mostly on the right, on the left also fourth intercostal space parasternal line. Okay, but if I heard a murmur here, if I heard a murmur here during diastole, what should be? It should be regurg, because normally the blood go like this. Okay, and this valve should be closed during diastole, and the blood shouldn't come. But if I hear a murmur in the second, during diastole, in the second left intercostal space, or in the second right intercostal space parasternal line, so I'm hearing aortic or pulmonary murmur. So it will be regurg. It will be regurg. So here it will be regurg. And both of them during diastole. Dr. Yasser, he will not ask you about details, internal medicine details, early or mid diastolic or late diastolic. What he needs from you to know, it is a diastolic murmur. Early diastolic, yes, it is early diastolic murmur with Kaza. He will not ask you with early and mid and late diastolic murmur. Really more details. Simply, I'll send you the table after we finish. Simply, he want to tell you during diastole, if you heard a murmur on the fourth or fifth intercostal space on the left, it will be a stenosis. If you heard it on the second, on the pulmonary or aortic area, it will be regurg, simply. And he will give you the space. There is a murmur in the second right intercostal space. So it is aortic stenosis during diastole. Okay, clear about diastole?
Yes, clear. Thank you.
Okay. This is the diastole. Let's go for, again, I'll have this again simply like this. Okay. During systole, this valve should be competent, and this valve should be open, and blood should go like this and shouldn't go like this. If during systole I have a murmur, where is the murmur? If it is here with the normal flow with the blood, so it should be a stenotic murmur. The same with diastole. If it is with the same normal flow of the blood, it will be stenotic. Okay, if it is reverse blood, if I hear this on the fourth parasternal left or fifth mid clavicular left space, it should be mitral or tricuspid on the other side. So it will be, blood will go like this. So this is incompetent. So this is regurg. So it will be regurg. Is it clear?
Yes, it's clear.
Is it clear? Try to revise it many times. Sometimes it's not clear. Try to revise it many times. It will be so clear, by the way, and it's so easy. It will be so clear and so easy. You can do it like this. Okay, and see. We can make it like this and say here during diastole, or here during systole. If the murmur go with the direction or against the direction, okay? So if it go with the direction in diastole, so the diastole, the normal direction of the blood through the mitral valve from the right atrium to the left, to the right ventricle, or from the left atrium to the right to the left ventricle. Okay, right to right or left to left, whatever, from the atrium to the ventricle. If it is go with the blood, so it will be stenosis. If it is in the reverse or against the normal flow of the blood, like in diastole, you shouldn't have any murmur on the pulmonary or aortic. If you heard a murmur, so this is incompetent, so there is regurg. Okay, so this is mitral or tricuspid, and this is aortic or pulmonary. And the other side here, if I have a systolic with, so I should be with the mitral, so it will be with the aortic or pulmonary. Aortic and pulmonary, so I have a problem with the blood flow, so it is stenotic. Reverse the blood against the normal flow during systole. What is against? Mitral or tricuspid. So against, so there is incompetence, so it is regurg. Clear?
Clear.
I think it's more clear now. Yeah?
Yes.
Okay. You are taking long time than I expect. Okay. I hope we can finish as much as we can. So this is mitral valves. Okay, this is a common problem with patients have rheumatic heart with pregnancy, and this is exacerbated during pregnancy. Okay, I forget who's next. I think we'll start from Dr. Farah again.
A 10-year-old child is admitted to the emergency department after a fall. On examination, the blood pressure is 100/55. Pulse rate is 90 beats per minute. Abdomen is short but tender on the left. Abdominal imaging demonstrates a grade 3 splenic laceration. What is the most important appropriate course of action? Undertake a immediate laparotomy and splenectomy. Undertake a laparoscopy and laparoscopic splenectomy. Admit the child to HDU for close monitoring. Arrange splenic artery embolization. Undertake a laparotomy and splenic repair. As the patient is hemodynamically stable and there is grade 3 laceration. I don't know the answer, but I think C should be the answer to this. Admit the child to the HDU for close monitoring because the patient is hemodynamically stable as well. The patient has grade 3 laceration only.
Exactly. This is a protocol in UK, maybe different in our countries. In our countries, I think as we have any patient with splenic trauma, mostly we don't have the capability for doing conservative treatment for a splenic trauma, and most common splenic trauma we have with moderate bleeding or more moderate to severe bleeding. In my life, maybe now I'm more than 10 years now in surgery. I did conservative treatment for splenic trauma and perisplenic hematoma twice in my life. And it was a very challenging for me, and it was very challenging for the whole department. In my hospital, I was working in Egypt, and even as I had many instructions from my manager and from some of our consultants to go for splenectomy, not to wait for this. But I prefer to wait, and some patients waited for me about 10 days, and the other patient about 12 days. But the patient went home in peace, and he's completely fine after about more than 10 days with perisplenic hematoma, because he was hemodynamically fine. His hemoglobin was more than 9, and with blood he's improving, but he went conservatively for more than 10 days. But it is not common practice in our countries. However, here in UK, up to grade 3, patients go for conservative treatment starting from grade 4 or grade 5, which is the avulsion or complete avulsion is grade 5, or splenic pedicle injury. They have to go for splenectomy.
Excuse me, I have a question.
Much more cases. Splenic laceration performed only 2 cases of 60 cases. Perfect. Where is Dr. Yasser?
Excuse me, I have a
Here
question.
in Alexandria University. Yeah, I guess we are in Egypt, and also we have the protocol of conservative.
No, we were in Hurghada, and in even Asyut University, we do splenectomy for most cases.
I don't know.
But we have very severe accidents, very famous in Red Sea, with bus accidents and something like that. But yeah, I did it twice in my life.
Yeah. Okay.
But this is perfect. I first time to know about Alexandria that they do it conservative. Perfect. Okay.
Excuse me, I have a question. Yeah, if it is a grade 4, for example, hilar injury grade 4, and we are going with choice A or B, immediate laparotomy or laparoscopy? And
mostly we go with immediate laparotomy and splenectomy, open laparotomy.
Yeah, okay.
Open laparotomy. I think with bleeding and avulsion, and you can't go with laparoscopic with bleeding. This is because grade 4 and 5 you are going with avulsion or complete avulsion or laceration or for the splenic pedicle. So you can't go for laparoscopic splenectomy.
Okay, thank you.
Whatever, he will not ask you about these details, because just put in mind, we have many orthopedic surgeons, we have many plastic, we have many ENT, We have many urology doctors. So he will not go for more and more details, by the way. Just he want to grade 1, 2, 3 conservative, grade 4 and 5 will be conservative. It will be go for surgical treatment.
Surgery.
Excuse me. Hello. Can I ask a question, please? Hello.
Okay. Yes. Okay.
Hi, sir. Okay. So I'm saying that the normal blood pressure for a child 10-year-old is 120/80. This child's blood pressure has fallen to 100/50. Doesn't that say the child is bleeding actively already, and the child will need urgent intervention?
Blood pressure 100/55, and pulse rate is 90.
Yeah, I'm saying that the normal blood pressure for this age is about 120/80.
But up to 100 and more, the patient is stable.
Sorry?
Patient is stable. 100 and more systolic blood pressure, the patient is stable.
Okay.
And you'll know this in part B.
Okay. Okay.
Okay. They consider the patient, even in communication skills station, you will have in part B, you will have a patient with cardiothoracic trauma and his blood pressure is 100/60 or something like this. And he will ask you, is the patient stable? According to his blood pressure, according to his pulse rate, this patient is almost stable.
Okay, thank you.
Okay, Dr. Michael.
Dr. Rami, if I may interrupt.
Okay.
Thank you. I was just going to add. That the age of the patient, that is being a 10-year-old child, is also quite important in the question, because generally in the UK, it is always advisable to conserve the spleen.
Yes, exactly. You are right.
In children,
yes.
So that's why the issue of the age of the patient should be considered.
Yes,
it's best
exactly.
to always conserve spleen as much as possible.
Exactly. In UK, and many countries now, in a young patient or child, they do whatever they do to preserve the spleen as they can, and sometimes splenic wrapping and splenic suturing. And few days ago, some surgeon in one big surgery page on the Facebook, I have read that a case of splenic suturing, and it was a very interesting case, by the way. So trying to preserve the spleen as much as possible as it can is important in child. Okay, Dr. Farah, تفضلي.
Hello, actually, I have to go. My apologies. We have so time here, so maybe I can watch your offline link of this video.
Okay.
I can't participate in. Thank you so much.
We talk long time now in 9 questions. I don't think that we can reach about. I expected to go for about 40 to 45 questions today. Okay. We'll
Thank you
try
so
to
much.
go faster. Okay, you are welcome, Dr. Farah.
It's 3 a.m. here, so I have to go.
Okay, and we are sorry for this late time. Thank you.
No, it's fine. Thank you.
Okay. Okay, who's next, please? Just want to go a little bit faster, please. We just really. Okay, Dr. Khalifa, تفضل.
مواهب.
Dr. Khalifa.
A 24 years old motorist is involved in a road traffic accident in which he collided with the wall of the tunnel in the head on car crash. Speed 85 mph. He is wearing seat belt and the airbags have deployed. When rescuer arrived, he is lucid and conscious and then died suddenly. What is the most likely underlying injury? Patient pneumothorax, aortic dissection, splenic rupture, hemopericardium, tracheobronchial dislocation. I think aortic transaction.
Yes, exactly. Mean right. B. Yes, exactly. I think we discussed about this. And we said give time for the patient to die, but other causes here like tension pneumothorax, splenic rupture, tracheobronchial dislocation. Tracheobronchial dislocation may cause patient to die at once, by the way. This is an airway ABC, so the patient can die at the scene of accident. Tension pneumothorax, no, the patient will not die with this picture. It's a different scenario. Splenic rupture is the same. The patient is not shocked. It's a traffic accident, colloid, tunnel, and the patient car crash, speed, wearing seat belt. This typical picture of a patient with aortic transection. And we said the patient sometimes reaches the hospital and then die at hospital or die at home if the disruption is distal to, or the transection is distal to the ligamentum arteriosus. Okay.
Yes.
Okay. Next question. Who's Dr. Ghada?
Yes. Okay. A patient is brought to the emergency department following a motor vehicle accident. He is unconscious and has a deep scalp laceration. His heart rate is 120 per minute, blood pressure is 80/40, and respiratory rate is 35 per minute. Despite rapid administration of 2 liters of Hartmann solution, the patient's vital signs did not change significantly. The injury is likely to explain this patient's hypotension is epidural hematoma, subdural hematoma, intraparenchymal brain hemorrhage, base of skull fracture, none of the above. So he has hypotension with tachycardia, and after resuscitation still has hypotension. So maybe there is a chest injury or intraperitoneal injury, not related to the skull injury. So I will go with none of the above because it is not mentioned as abdominal or thoracic cavity injury.
Exactly. This patient has tachycardia and hypotension. So this is hypovolemic shock and all due to bleeding, whatever intrathoracic and or intra-abdominal, but all here causes here or all choices here is related to brain injury, and he just want to make you confused with okay, sorry. He just want to tell you the difference between Cushing syndrome, Cushing response, or Cushing reflex, and hypo or hypovolemia. In Cushing response or Cushing reflex, the reverse will happen. The patient will have hypertension and bradycardia with irregular breathing rate. Okay, just you want here to know, do you know the difference between Cushing reflex or patients with normal hypovolemia? As Dr. Ghada said, exactly, this patient should have or may have interperitoneal or intrathoracic hemorrhage with hypovolemia. Okay, next question. Dr. Khalifa.
82-year-old.
Okay, you want to participate? It's okay. Okay, go.
32-year-old female hit her head on a steering wheel during a collision with another car. She has a periorbital swelling and a flattened appearance of the face. What is the most likely injury? Leaford 1 fracture affecting maxilla. Leaford 3 fracture affecting maxilla. Mandibular fracture. Unilateral fracture of the zygoma. isolated temporal bone injury. 32-year-old female head injury and collision with another car with periorbital swelling, flat appearance on the face. Okay, I will go with leaf 3 fracture affecting maxilla.
I think most here, okay. D4-3 Exactly, this patient has a flattening of the face and it's a cardinal sign from D4-2 and D4-3, by the way. D4-1, the patient have just fracture of transverse to the maxilla, but as a patient, the fracture reached to the base of the orbit with the periorbital, as he mentioned, the periorbital swelling. The patient would have a depression in all the maxilla, nose, and the infraorbital part will be depressed backward, so the patient will have a flattened face. This, by the way, is very common with D4-2 and 3. D4-3 will affect the upper orbital ridge. D4-2 just affect the base or the inferior orbital ridge together with the maxilla. Okay. Okay, next question. Whose turn after Dr. Maadda? Can't remember whose turn.
Number what? Which number?
I go after Dr. Maadda, Dr. Ali, I think. Okay.
Yeah, okay. 20-year-old man is trapped in warehouse fire. He has sustained 6% burns to his torso and limbs. The limb burns are partial thickness, but the torso burn are full thickness. He was intubated by paramedics at the scene and is receiving intravenous fluid. His ventilation pressure requirements are rising. What is the best course of action? Okay, 60% burn, torso and limbs, partial thickness, full thickness. Ventilate the patient in the prone position, echarotomy, extubate the patient. Yeah, echarotomy, extubate the patient, undertake skin graft, transfer to burns unit. Okay. The problem here is ventilation. The pressure requirements are rising. What is the best course of action? Thickness. Yeah, I think this is kind of
Eschorotomy.
Yeah, eschorotomy, but this is what is the relationship between ventilation and partial thickness? Yeah, I think this compartment syndrome, because we said that this
in chest. No, not compartment. There is no compartment syndrome in chest.
I mean the partial thickness, the limb burns are partial thickness.
We don't have any problem with the limb here. The patient is intubated by paramedics and seen, and is receiving intravenous fluid. His ventilation pressure requirements are rising. His ventilation pressure requirements are rising. They want to make more positive pressure to exactly have limited chest movement.
Yeah.
Because of any problem, whatever fracture or whatever, something constricting the chest movement. So you have to increase the positive pressure volume of the ventilator to counteract the restricted chest movement. This means that he has a problem with the chest movement, and we have a full thickness burn around the torso. So the problem may be from this full thickness. So you have to go for eschorotomy.
Yeah, this is full thickness because it's
okay, so this is a problem why
this can become hard. So it's difficult to move. The chest difficult to move.
Okay, this is a problem with the ventilation for the patient. Okay, who will go for this long scenario? Who's next? Doctor
محمد رضا.
دكتور أحمد أوكي تفضل.
Yes. Please, I can't read the first line.
Okay, wait, we can do it like this.
Yes. A 24-year-old man is admitted to surgery with acute appendicitis. He is known to have hypertension, psoriatic arthropathy, and polymyalgia rheumatic. His medical therapy includes paracetamol 1 gram, codeine phosphate 30 milligram, bendrolfolozib 2.5 milligram. I don't know this.
Okay, this is the medication of the patient. He is taking, what's important for you, he's taking methotrexate, he is taking prednisolone for his case. Okay, continue.
Yes. Okay. You are called by the core surgical trainee to assess this man as he has become delirious and hypotensive 2 hours after surgery. His blood results reveal sodium is low, potassium is high, urea, I think it's okay, creat, I don't know creat by micromole.
More or less normal.
Okay.
Glucose is?
Glucose 3.5, CRP 158.
Glucose is? Low.
Low.
Low. Okay.
Okay. What else? Hemoglobin is okay. Platelet okay. IBC is high. Okay.
So what's most, by the way, in the exam, no long scenarios will come like this, okay? The scenario will be much shorter and he will give 2 or 3 parameters, 4 parameters maximally, and he will give you the normal value. In exam, you are not required to know any normal values. Even in part B, they are not asking you about facts about normal values, because now even in all labs all over the world and all hospitals and most centers, you have a chart and you have the normal values of everything you want to know in front of you in a table or a paper or on a screen. It is not normal, or it is not required from you unless very limited parameters like sodium, potassium, or hemoglobin. Okay, even in exam, he will give you the normal hemoglobin.
Yeah.
Okay. All recalls in the exam, he will give you everything.
Yes, I think it's acute adrenal failure. I think.
Exactly. So this is okay. This is hyponatremia, hyperkalemia with hypoglycemia, happens with acute adrenal failure. So what do you expect? So most likely diagnosis here?
Diagnosis: septic shock secondary to appendicitis, no. Neurotropic sepsis, fibrinocytoma, perforated bowel, Addisonian crisis.
Addisonian crisis. This is a picture of Addisonian crisis, and by the way, this is a very common question in the exam. And he will give you the normal parameters. Don't be scared by any parameters in the exam. Even hemoglobin, he gives you the normal parameters. So this is Addisonian crisis. Okay. Sudden corticosteroid failure, adrenal failure. So the patient has low cortisol in blood, and this important to maintain the normal sodium and normal potassium with normal glucose level. Features of Addisonian crisis is hyponatremia, hyperkalemia, hypoglycemia. Okay?
Yes.
Next question, Dr. Doffer. Okay, Dr. Doffer, then Dr. Mumtaz, if you want to participate. Dr. Doffer, are you here? I don't think. Where is Dr. Doffer? Okay, Dr. Mumtaz, you can go.
26-year-old electrician suffers a full-thickness high-voltage burn to his leg. On routine urine analysis, he has 1+ blood. His urea and electrolytes show mild hyperkalemia and a creatine kinase of 3000. What is the most likely explanation? Deep vein thrombosis, disseminated intravascular coagulation, rhabdomyolysis, myocardial infarct, glomerulonephritis. It is rhabdomyolysis.
Okay, this is two features. Okay, it's two features of rhabdomyolysis, with burn, coming with high voltage burn, and the patient has hyperkalemia and creatine kinase of 3000. This is happen with rhabdomyolysis.
Hemoglobinemia.
Okay. Hemoglobinuria. Okay.
Yes. Okay.
Positive blood in the urine. Next question.
A 32-year-old man is involved in the motorcycle accident and sustained a closed and stable spiral tibial fracture. This is the mini twist and intermedullary nail. On return to the ward, he is not to have increasing pain in the limb, and on examination, the limb is swollen and tender with pain on the passive stretching on the tooth. The most likely diagnosis is compartment syndrome.
Okay, I think it's easy. Many of you have answered CCC. This is cardinal features of compartment syndrome. Okay, cardinal features of compartment syndrome. The patient has passive stretching of the compartment. Passive stretching of the compartment, and very common with fracture upper limb ulna and radius, very common, and very common with fracture tibia or fibula, or patient went for operation like intramedullary nailing without opening the fascial compartment of the leg during the operation. This is very common, maybe iatrogenic or maybe traumatic for the patient. By the way, just put in your mind that in compartment syndrome, when you tell passive stretching of the compartment or the toes, put in your mind that you passive stretching of the compartment, not dorsiflexion of the leg, will cause pain, because we used to do Hoffman sign, which is dorsiflexion of the leg will cause pain with DVT, or sometimes if you have a compartment syndrome in the posterior compartment of the leg. In part B, you have to say it is passive stretching of the compartment. Okay, sometimes you have an anterior compartment or lateral compartment or posterior compartment, any compartment of this. When you passive stretch the compartment, you will have the pain, and this is one of the cardinal signs of compartment syndrome. Okay. This is simply pain, special movement, even with passive. Paresthesia, pallor, arterial pulsation. You have to say it is the last sign plus paralysis of muscle group affected. So paralysis of muscle group affected, or passive pain on passive movement of the muscle group affected, plus some paresthesia, some pallor, and lastly, arterial pulsation be lost, and it is a very bad sign. Okay, next question.
A 55-year-old man. Yes, a 55-year-old man is involved in stabbing and receives an injury to the left iliac fossa. After transfer to the hospital, he is taken immediately to the theater because of hemodynamic instability. At laparotomy, an injury to the colonic mesentery is found to be the cause of blood loss. There is an associated injury to the left colon with a local perforation and contamination. What's the most appropriate course of action? Undertake repair of descending colon and place drains. Resect the colon and perform an end-to-end anastomosis. Resect the left colon and construct left iliac fossa and colostomy. Place an omental patch for the defect in the colon and drains adjacent to this, or perform subtotal colectomy and ileostomy. So there's colonic injury, and there's contamination with perforation, patient hemodynamic instability. In case of emergency, we do Hartmann. We resect that part of colon if there's a lot of contamination with end colostomy. So C, it's reasonable because there is no omental patch option for colonic injury. No end-to-end anastomosis in case of hemodynamic instability in case of emergency.
It is in sepsis even. You don't do in sepsis.
Exactly, and
okay.
And also no repair for the first option, or the subtotal colectomy. I think it's for ulcerative colitis or something like that. But C option, resect the left colon and construct left iliac fossa and colostomy, which means Hartmann's. It's used for emergency in case of hemodynamic instability associated with contamination.
Okay, so there's the left iliac fossa, and he has perforation, chronic mesentery caused blood-associated injury to the left colon. Subtotal colostomy, remove all the right and transverse and part of just the splenic flexure. So we did the colectomy away from our injury. So exactly as Dr. Ghada, perfect Dr. Ghada explanation, we do end colostomy and Hartmann for septic patients.
Yes.
And emergent septic patient, we just do temporary end colostomy and Hartmann for the patient for further. Take care if right side it will be. Yes, exactly. If right side it will be different for sure. Okay. Next, what we will do if it's right side, as you mentioned?
Right hemicolectomy.
According, yes, right hemicolectomy, extended right hemicolectomy, whatever wherever the injury. Okay, next question, doctor. So, Dr. Ali, I think.
An elevated jugular venous pulse.
Okay.
An auscultation of the heart reveals quiet heart sounds. What is the most likely diagnosis? He has an elevated jugular pulse pressure and quiet heart sounds, and that's muffled heart sounds. Okay, so that'll be the Beck's triad. So it's likely to have a cardiac tamponade. That's the Beck's triad C.
Okay. So this patient. Okay, so this patient has so this patient has elevated jugular venous pulse and muffled or quiet heart sounds. That means that the patient has a pericardiac bleeding or cardiac tamponade. But if this patient has an empty jugular veins, what do you expect for this patient?
For empty jugular veins,
sometimes you see empty jugular veins and the patient has also maybe muffled heart sounds or distant heart sounds. Exactly, Dr. Ali, hemothorax. The patient has a bleeding. intrathoracic bleeding. So that's what differentiates between patient has distant or muffled heart sounds. Maybe the patient has intrathoracic bleeding, so you can't hear the heart sounds clear, okay? And that you can differentiate between cardiac tamponade by Beck's triad. The patient has congested elevated neck veins, and between the patient who has an empty neck veins together with muffled heart sound. So this patient mostly have intrathoracic bleeding, okay?
Okay, thank you.
Okay, welcome. Okay, next doctor.
Ahmed Rida.
Okay, Dr. Ahmed, go.
60 years old alcoholic, presents with worsening confusion over 2 weeks. He has weakness on the left side of the body. What is the least likely explanation? Least likely?
It is the least likely explanation. Patient is alcoholic. Patient has worsening confusion over 2 weeks and weakness on the left side of the body. This patient is alcoholic. Can this patient has vernix encephalopathy?
Yes, he can.
He can. Does this patient can have an extradural hematoma?
Yes, I think yes.
Extradural without any trauma?
Extradural, maybe with repeated minor traumas.
Okay. Can this patient has decompressed liver failure?
Maybe.
Maybe. He's alcoholic. Can this patient has subdural hematoma?
Maybe.
This patient is old age, alcoholic.
The subdural, not extradural. Yes, I think.
Subdural he can have.
Yes, yes.
Vascular dementia.
Yes, maybe.
Okay, so the only thing the patient can't have is extradural hematoma, because it is not common with this patient without any trauma, but it is very common with minor trauma, especially in old age alcoholic patient with dementia, that he may have repeated minor trauma that he may cause, and his brain, the brain atrophy means any concussion or any deceleration, acceleration, movement of his brain can cause just laceration on the small venules between the dura and the brain that have this subdural hematoma to happen, okay?
Yes.
So the least likely explanation is the extradural. Put in mind in your exam, put in mind to read the question perfectly. Put in your mind what is all except, what is false, what is correct, what is the least like, and what is the most likely explanation, okay?
Yes. Yes.
Okay, Dr. Ahmed, then Dr. Ali.
Yeah, okay. 22-year-old man suffered 20% partial and full thickness burn in house fire. There is associated inhalational injury. It is decided to administer intravenous fluid to replace fluid losses. Which of the intravenous fluid listed below should be used for initial resuscitation? Dextran 40%, 5% dextrose, fresh frozen plasma, Hartmann solution, blood. Yeah, for sure, Hartmann solution in burn.
Exactly. Burn, whatever the formula we start with
Ringer
crystalloids, ringer lactate, exactly. Ringer lactate is the most common we use for patients with pain according to the formula we use. Parking formula, most commonly we use it for the patient in the first 2 days, and this will be Hartmann solution, okay? We don't like to give fresh frozen plasma or blood in the first 24 or 48 hours because this may aggravate the problem with the patient. Okay, we don't like to give colloids, preferably, and don't give in the first 1 or 2 days, first day or second day. Next question. Dr. Ahmad, please just mute your audio when you just, okay. Dr. Start again, okay. Dr. Mawahib, you can start again.
An 18-year-old student is involved in a car crash with another car crashing into the side of the car. A chest X-ray show indistinctly left hemodiaphragm. What is the most likely diagnosis? Diaphragmatic rupture, acute phrenic nerve rupture, cardiac tamponade, tension pneumothorax, aortic rupture, diaphragmatic rupture.
Okay, I think it's one of the easiest questions you can face in the exam. It shouldn't take more than 10 seconds in the exam, by the way. You don't have to take the 40 or 60 seconds for every question. Some questions like this question will, sorry?
Then I failed it then because I was thinking it's, acute diaphragmatic nerve injury, phrenic nerve injury.
What? I can't hear you.
I said I failed the correction then. I was thinking it's a phrenic nerve injury.
Diaphragmatic injury.
Okay.
Yes? Okay. This is, you can indent diaphragm or indent hemidiaphragm. This means this patient has a diaphragmatic injury. Sometimes you tell you bowel loops, you can auscultate or you can see an X-ray. This is the main also one of the symptoms or signs you can see in patients with diaphragmatic rupture. Next question. Dr. Ghada. Dr. Ghada, are you ready?
Yes. Sorry,
Okay.
I was muted. Okay, a 31-year-old lady is struck by a car and is 32 weeks pregnant. On arrival in the emergency department, she has systolic blood pressure of 105 millimeter and pulse rate of 126 beats per minute. Abdominal examination demonstrates a diffusely tender abdomen and some left-sided flank bruising. A fast scan is normal. What's the most appropriate course of action? Arrange a department abdominal ultrasound scan. Arrange an urgent abdominal MRI scan from a laparotomy. Perform a diagnostic lavage. Arrange urgent abdominal CT scan. For the new guideline, it is in the 3rd trimester for CT scan. Because the fast is not reliable in pregnancy, she's already
has less sensitivity.
Yes,
this patient has some signs of internal hemorrhage, like hypotension, at least hypotension, maybe class 1 hemorrhage, but it is tachycardic. Normally you have tachycardia in pregnancy, but not 126. You normally have tachycardia, hyperdynamic circulation pregnancy, but not like this, not 126. So the patient and tender abdominal examination. So all this bruising, tender abdomen, tachycardia, hypotension. So the patient has something suggestive or signs suggestive of internal hemorrhage, maybe even class 1. So and fast gives you free. Her fast is free, and this is suspected because fast has low sensitivity in pregnancy. So the patient, it's better to go for CT in pregnant patients third trimester. It is exactly imaging in pregnant trauma. Sensitivity of fast is 60 to 80%, so you have to go for CT scanning. Okay, next question. Okay, Dr. Sarah, you can go for next question.
Okay. Okay, a 28-year-old woman who is 30 weeks pregnant presents with sudden onset chest pain associated with loss of consciousness. Her blood pressure is 170/90 mmHg, saturation of 15 liters of oxygen, about 33%, heart rate 120 beats per minute, and she is apyrexia. In examination, there is an early diastolic murmur, occasionally by basal crepitations and mild pedal edema. ECG shows ST elevation in LEDs 1, 3, AVF. What is the most likely diagnosis? 30-week pregnant, present with sudden onset chest pain with an associated loss of consciousness. Her blood pressure 170/90, saturation 15 liters, OSAD is 93, heart rate is 120. She's apyrexia. Examination, there is early diastolic murmur, occasionally by basal crepitations and mild pedal edema. ECG shows ST elevations in LED 2, 3, AVF. Aortic dissection is possible, I think. Hello?
Okay. Yes.
I think aortic dissection.
Aortic dissection.
Mm-hmm.
Okay. Let's see the answers. Dr. Mohammed B, Dr. Ali B. All
Yes,
the same.
aortic dissection. Yes.
Okay, and what's your explanation about
there is she has inferior MI with diastolic murmur. This combination is going with aortic dissection.
Okay. And the ECG?
There's ST elevation in the inferior piece. There's the inferior MI, and there's bibasal crepitation with mild pedal edema, maybe for features of cardiac failure or something like that. But in the, there is diastolic murmur, as we mentioned before. Diastolic murmur, it goes with some valvular disease like mitral disease or something. In case of inferior MI, there's something related to the aortic root itself. So it's mainly aortic dissection. Yes.
Exactly. Embolism. Sorry. Okay. Is a typical case of our, sorry.
Yeah, I have comment on the aortic stenosis.
Okay. Okay, Dr. Ali, tafadhal.
Okay. With the aortic stenosis, we have tried, it's called, it consists of angina pectoris, chest pain, and near syncope or syncope, like this case, and dyspnea, shortness of breath. And I think this case maybe have aortic stenosis, maybe.
Okay.
Yeah, so because of hypertension, aortic stenosis is also associated with hypertension. So hypertension maybe it's due to pregnancy. So there's maybe a risk of aortic dissection. That's that's responsible for chest pain and heart
Yes,
failure.
exactly. Aortic problem like aortic stenosis has symptoms of aortic stenosis are, you can divide in three parts. Okay. First, and this is very common by the way in Part B exam, when you ask you about symptoms of aortic stenosis, you have to start with maybe asymptomatic. Okay. Second category is anginal pain, syncopal attack, and dyspnea, anginal pain, and syncopal attack. And the third is complicated patient, which come with orthopnea, paroxysmal nocturnal dyspnea, and sudden death. Okay, this is the three categories you have to go. If you ask it, what is the problem with patient clinical signs of aortic stenosis? You have to do three categories. First one asymptomatic, second one symptoms, which is 3, dyspnea, angina, syncopal attacks, and then complicated cases. You can go for orthopnea, paroxysmal nocturnal dyspnea, and sudden death. Okay. One of them is the aortic dissection that happens. The patient comes with hypertension. The patient, when having hypertension, this is very common, especially with Marfan syndrome and bicuspid valve and something with rheumatic heart valve disease. The patient may have aortic dissection, okay, and come with this picture. So how he wants you to know about aortic dissection. Here is early diastolic murmur that happened with aortic regurg. Okay.
Yes.
Early diastolic murmur that happens about aortic regurg. So the dissection reaches the aorta, the aortic valve, so happens aortic regurg. And also affected the right coronary artery and cause inferior MI. ST elevation in lead 2, 3, and AVF. I'm not expert in ECG, but this is signs of inferior MI because of affection of the right coronary artery. Okay.
Yes.
This is simply what happens. This is aortic dissection and happens with pregnant woman. Third trimester has aortic valve problem. She has an early diastolic murmur. Bipedal crepitation, and mild pedal edema. She have an aortic. She has an aortic stenosis problem. Aortic stenosis for long time. So this patient has this basal crepitation, has a right-sided heart failure, a left-sided heart failure, or a starting of left-sided heart failure. So the patient has basal crepitation and pedal edema. And when happens the dissection, happens this problem for the patient. When the dissection happens, the patient suffers from a mitral valve problem in the form of mitral regurg, early diastolic murmur, and right coronary artery affection with the picture of inferior ischemia. Okay? It is not the picture of pulmonary embolism by any way. Okay, in pulmonary embolism, the patient will be hypotensive, not be hypertensive. And there is no relation with the ST segment elevation. Okay. The ECG for pulmonary embolism will be different completely. Did anyone remember the ECG for?
It is S1 Q3 T3, I think.
Yeah,
again.
S1. Yeah, S1 Q3
S1 Q3 T3.
S1,
Q2,
Q3,
T3. Yes.
T3. This is a cardinal, and this will have you in the exam. You will have this, by the way, in the exam. If he wants you to know about the pulmonary embolism, he will tell you the patient has S wave in lead 1 and Q wave in lead 3 and inverted T in lead 3 as well. Okay.
Yes. Yeah.
Okay, next question, doctor. Who wants to participate?
Me?
Okay, Dr. Ahmed, go. No
Okay.
problem.
A 28-year-old man falls and sustains a multiple rib fracture. On examination, there is a small pneumothorax. What is the most appropriate course of action? Discharge with advice to return of sample person, insertion of chest drain, admission for observation, CT scanning of the chest, thoracocentesis. Small pneumothorax. Admission for observation.
Okay, anyone has different answer? C. Whole admission for observation.
Just a tube. There is pneumothorax.
Dr. Adam.
Yes, I said
Chest
just a
tube,
tube.
small
Chest drain.
pneumothorax. Chest drain, you go for a small pneumothorax for chest drain.
To make it larger. There's pneumothorax by default. Why should
No,
I
no,
observe him?
this is not the answer. This is not the answer. In cardiothoracic, you have some parameters, maybe sometimes with empirical parameters, when you go for a chest tube, by the way. If the patient just coming for trauma without any fracture, without any penetration object, and you take from the midline to the peripheral of the chest, this was empirically told to me by a cardiothoracic surgeon. If the amount of air is less than third or a quarter of the width, you can go for conservative treatment. But this is not the cause.
Okay.
Anyone has why we'll go here for conservative or chest drain?
Because of simple trauma?
Sorry?
Because of simple trauma? Because simple fracture?
You have a rib
just
fracture.
observation?
Okay. You have, yes. No. If you have a rib fracture, even with a small pneumothorax, you have to go for chest drain. Okay. You have two causes of small pneumothorax or pneumothorax. You have medical causes and you have surgical causes. Even in surgical causes, if it is just a trauma and the patient have a minor pneumothorax and you don't know why, maybe the patient is smoker and has a small poly and it is ruptured accidentally, you can go without. But most cases of trauma, you will go for chest. You will go for chest drain. But in medical cases, you can go for conservative treatment. But you have a trauma or you have a fractured rib, you should go for chest drain. Okay.
Yes. Okay.
Clear about this?
Yes, clear.
Not just in medical case, if a smoker.
Medical case, if it is a small pneumothorax, is very common. By the way, you can see someone in the street that has emphysema or smokers for a long time and have small poly ruptured, and he don't go to the hospital, and he can accidentally discover that he has an emphysema.
Yes.
and he spontaneous recur. This is very common in emphysematous patient, by the way. But in surgical patients, especially if you have fracture rib, so the patient may have a problem with valvular lesion in the pleura, and the patient may go for tension pneumothorax in few minutes, in no time. Next question.
Okay, surgical. Okay.
Okay,
So,
sorry. If
just
surgical, you go for just.
Okay, just the last question, because I'm confusing. If he's just a smoker, the small amount, we can observe him. But if there is a ruptured poly and emphysema, we go for chest drain?
If
Or
it's
just for observation?
trauma with fracture rib,
yes.
Even if it is a small amount, you will go for chest drain.
Okay.
Medical cases, small pneumothorax, go for observation. Medical cases, maybe small poly ruptured, and it will go spontaneous. Okay.
Okay. Thank you.
Okay. Okay. Next question.
Yeah. Shall I start?
Okay, Dr. Ali. Okay.
A 14-year-old boy is admitted to the acute surgical unit with appendicitis. He's normally fit and well. Apart from metoclopramide, the patient has had no other medications. The nursing staff contact you as the patient is acting strange. On examination, he is agitated, has a clenched jaw, and his eyes are deviated upwards. What is the most likely diagnosis? We have functional disorder, malignant hyperthermia, oculogyric crisis, epilepsy, serotonin syndrome. I'm going with oculogyrus crisis. This is side effect of metoclopramide.
Exactly.
It's called extravaginal.
He just want to يعني هو عايز يغششك الإجابة. He just tell you the patient, apart from metoclopramide, he is taking no medication and has this problem. From all the scenario, you have nothing. You have nothing to search about what is the cause of the problem except of metoclopramide.
Yeah,
okay?
I have just one comment.
It is clear scenario. 14 years old, acute surgical unit with appendicitis. Okay, what is the problem? Fit and well. Okay. Apart from metoclopramide, he's taking nothing. He want to tell you what is the problem that may happen for the patient with metoclopramide. This is clearly, by the way, in the exam, questions are so easy and so simple, and are not confusing, are not so tricky, and almost not tricky. The tricky question less than 5%, and this will not affect your results, and most results will pass because pass rate is around 70. So to get 80 to get 85 is very easy. More than 80% of questions are not tricky, are straightforward for non-surgeons. Okay.
I just want to add information. Yeah. About metoclopramide. Metoclopramide, is work on is act on the dopamine D2 receptor on the chemotrigger zone in the brain. So to cross the blood-brain barrier, this is the first thing important. So it has the CNS manifestation, and it's also work peripherally on stomach and intestine. And its work also, I read about it a few days ago. It's work on to activate 5-HT receptor 3 and 4. On 3, it's antagonist, and on 4, it is agonist. So this is the mechanism of action of metoclopramide.
Okay. We don't need more. Okay, it's very nice information from you, but really, for those who don't know this information, don't confuse yourself. As I told you, information about the about pharmacology is not so many in the exam. Less than 10 questions in both papers. So just know, and they are repeated many times, frequently in recalls. No new questions you will be asked about. Maybe if one Okay, forget about it. You're not going to study pharmacology by all actions, side effects, and contraindications and the indication for just 10 questions. Okay. Nice. Thank you, Dr. Ali. Thank you. Nice information. Okay. Next question.
6 years. A 6 years old boy pulls over a kettle and suffer a superficial partial sickness bare to his leg. Which of the following will not occur? Preservation of hair follicles, formation of veins or bullae, damage to the sweat gland, healing by re-epitheliation, pain at the bare side. Which of the following does not occur? I think it not damage to the sweat gland because it is superficial partial sickness.
Exactly. Sorry, I'm going to unmute you. Sorry, because the noise background. Thank you. And where's the baby is fine. Okay. This superficial partial sickness, burn that affect the epidermis and the superficial layer of the papillary layer of the epidermis, and it will not go for the sweat glands, but hair follicles will be preserved. Yes. Will occur, formation of vesicle will occur, healing by re-epithelialization will occur, pain because nerve endings are intact will occur, but damage of sweat glands you have to go for full sickness or deep partial sickness burn. Okay. Superficial partial sickness burn will go only for will cause burn or affect only the papillary layer of the epidermis. Next question, Dr. Gada.
Okay. You are called to the acute surgical unit. A patient who has short gut syndrome has developed a broad complex tachycardia. You suspect a diagnosis of ventricular tachycardia. What's the most likely precipitant? Hypoglycemia, bisoprolol, hypomagnesemia, dehydration, or hyperthyroidism? Short gut syndrome with tachycardia. I think hypomagnesemia associated with ventricular tachycardia because something related to electrical disturbance.
Exactly.
Okay.
Hypomagnesemia will cause ventricular tachycardia, and also it will cause what's called Trousseau sign. Trousseau sign. We will face this question, and this is caused by hypomagnesemia, and the treatment is giving magnesium IV.
Magnesium sulfate.
You mean Torsade de Bois, Dr. Rami?
Torsade de Bois, yes.
Yeah, it's called the Torsade de Bointes.
Torsade de Pointes, sorry, Torsade de Pointes. Torsade de Pointes. Okay. So the same, and we will have another question about this here. So this is the two questions that you'll face about hypomagnesemia and what it will cause. It will cause ventricular tachycardia, or will give you the twisting of points. Exactly. You don't know more details about it. It will come with the same name, caused by hypomagnesemia and treatment with magnesium. Next question. Who can go?
Yeah, you can go.
Wait, Dr. Ahmed, you have just noise background, Dr. Ahmed. You can. Dr. Ibrahim.
I think not me.
Not you? Okay. Not you, because you open and close the noise back. Dr. Ibrahim.
Hello,
welcome.
Dr. Rami.
Where are you?
Sorry.
You don't want to participate with us today?
Yes, for sure. I'm ready.
Okay, go. Dr. Ibrahim, one of our main and famous participants in our sessions. Okay, you can go for next question.
Thanks a lot, Dr. Rami. You are a great mentor.
Give rest for your friends.
Okay. Based on the current guidelines, which opinion regarding management of head injuries is false? Opiates should be avoided. Consider intubation if Glasgow Coma scale below 8 or equal 8. Immediate CT head if there is more than one episode of vomiting. Half-hourly Glasgow Coma scale assessment until Glasgow Coma scale is 15. Contact neurosurgeons if suspected penetrating injury. I think D. I choose D, Dr. Ram.
Choose D?
Yes.
This is false. You don't have hourly
I'm sure that
assess the patient.
B, C, and E are absolutely right. I'm sure of that.
B, C, and E. So you are confused between A and D, yes?
Yes.
Okay.
I'm not very
so
sure.
why you don't like to give opioid for patient and with head trauma?
Maybe just they cause respiratory depression. I'm not sure.
It causes sedation, opiate. Yeah, and we need the consciousness.
Okay.
Sedation also affecting the
this is
respiratory center.
absolutely should be avoided. So was Dr. Ali, what you think the answer?
Consider intubation, immediate CT scan. I think immediate CT scan is not right. It's more than one episode.
I'm
not sure.
I think that one is correct. Immediate CT scan if there is more than one episode of vomiting.
This is correct.
Yeah, it's correct.
2 or more episodes, you can go for CT.
Yes.
I was thinking maybe if the GCS is less than 7, not actually 8.
No, 8. This is right also. Less than 8, you have to intubate the patient. 8 or less, by the way, not less than 8. 8 or less, you have to intubate the patient.
Okay.
And you have to monitor the patient half-hourly till his GCS is 15.
15.
And
you have to contact the surgeon
or
if suspected penetration.
This is for sure indication for a neurosurgical consultation. One of them is penetrating injury or depressed skull fracture or basal skull fracture or rhinorrhea or blood in the ear or blood in eye, raccoon eyes or something like this is important also. Now still only A.
Okay. But
We
I
can
think
use
it's good
normally.
that
As I don't have any problem with respiration, there is no problem with opiates. We give low dose opiates for our patients. Yes. It is not completely avoided. Why avoid it? If the patient is agitated and the patient has has some seizures or have some pain. By the way, if the patient has severe pain and you are not relieving the pain, it is one of the participating factors in increasing intracranial pressure. In one of the guidelines for decreasing the intracranial pressure for a patient with high intracranial pressure and a patient suffering from Cushing reflex and you want to decrease the intracranial pressure, one of the things beside mannitol and beside giving diuretics, one of the, you have to relieve the pain of the patient up to opioids, because pain increases the intracranial pressure. You have to decrease the seizures of the patient, even if you go for hypnotics or sedative or total anesthesia, general anesthesia for the patient, and because these both are very important in decreasing the intracranial pressure for the patient. Okay, however, this page in front of you is a complete important station in part B about head trauma. Every point in this station is in details. This is a complete full station from A to Z. When the patient, when you patient is what we will do for summary guidelines for the patient with head trauma. When we will intubate this patient, indication for intubation for the patient, indication for C-spine injury when you will do X-ray and when you do C-spine. Okay. Excuse me. Okay. When you are going to contact a neurosurgeon in UK, you have to contact any consultant with full details and with accurate details, because it's easy to ask you, and this is very common in part B in communication phone call stations, that the consultant will ask you, so why you call me? You have about 6 to 7 stations about phone call. You are calling a consultant, informing him about a case. So you have a case with biliary injury and you are calling a hepatobiliary. You have head trauma and you're calling a neurosurgeon. You have patient with trauma and the cardiothoracic problem and fracture ribs, and you are calling the cardiothoracic consultant. And the first question he will ask you, so why you are calling me? The question is asking about what is the indication of calling a cardiothoracic surgeon maybe 2 o'clock in the morning for this case. This is, but he in communication skills, he tell you why you are calling me. So why you are calling me? Why you need me? You have to give him accurate information about when you contact a neurosurgeon, or when you contact a vascular, or when you contact a hepatobiliary, importantly, and at any time of the day if he is the on-call consultant. If you told him inaccurate information or incomplete information, he will tell you simply in the phone call, so doctor, is it indication to call me at 2 o'clock in the morning? Okay, doctor, bye-bye, and he will close the conversation. And it is a very bad impression in the exam. Clear?
Yes.
Clear, okay.
Yes.
Next question. Who is ready to go?
Yes, I'm ready.
Dr. Ibrahim, go for another question. Sorry, Dr. Ahmed, then Dr. Ahmed.
Okay.
Okay, Dr. Rami, thank you. A 30-year-old male is hit on the side of the head with a bat. He now presents to emergency department with odd behavior and complaining of a headache. Whilst waiting for a CT scan, he becomes drowsy and unresponsive. What is the most likely underlying injury? Intracerebral hematoma, subdural hematoma, extradural hematoma, intraventricular hemorrhage, subarachnoid hemorrhage. He is, I think, extradural hematoma.
Okay, what do you think this patient has? Or what is the scenario?
He has trauma to the side of the head.
Okay.
Then it caused headache and change of behavior. After then, he became unresponsive.
What you call this scenario?
You mean lucid interval?
Exactly. The patient has a lucid interval. The patient had a primary concussion, followed by lucid interval, followed by a sudden unresponsiveness. Sudden unresponsiveness. This is a typical picture of lucid interval and the typical scenario of lucid interval of extradural hematoma. By the way, extradural hematoma mostly will come to you in a young patient with head trauma, and he is normal and he's talking to you, and suddenly he will faint. Suddenly, instantly, he will be drowsy and loss of conscious or become unconscious. And it's very common in young patients. He will not. He likes an eMRCS to preserve old patient for the cases of subdural hematoma. Keep in your mind, he tell you a patient with 60, 65, 70 years and has a problem with dementia and he is alcoholic and then have a brain problem, blah, blah, blah. Mostly we'll go for subdural hematoma. Okay. If he want to ask you about an extradural hematoma, he will give you a young patient with trauma and lucid interval and sometimes lateralization, and then go, or sometimes he give you the CT or an X-ray show a biconvex or lens shape whitening or hyperdense area. All this he wants you to know about extradural hematoma due to middle meningeal artery injury at the anterior or the side of the head. Even he will mention for you a side of the head. By the way, the questions of neurosurgery are very easy. He just want to tell you the answer. Young age, trauma to the side of the head. He want to tell you this is trauma to the middle meningeal artery. So what do you expect? It is extradural hematoma. Okay?
Yes.
Next question.
Yes,
Dr. Ahmed, تفضل.
Yes. A 23-year-old man sustained a severe facial fracture and reconstruction is planned. Which of the following investigations will facilitate preoperative planning? Mandibular tomography, magnetic resonance scan of the face, skull X-ray, computerized tomography of the facial bone, orthopantomammogram. I think computerized tomography with facial bones.
Exactly. Maxillofacial surgeon in facial trauma, mostly they don't proceed for operation without a CT facial bones. Okay, when they are going for a reconstruction for any facial fracture or bones like maxilla, nasal septum, Leforte fracture or something like this, they like to go for CT facial bone before they go for operation. MRI is more for soft tissue. MRI is preferred mostly for soft tissue. In general, even in UK, if you want to see a problem with the spinal cord in the neck, or even a problem in the brain after you done CT, if you want to go for more details about the brain, you will go for or the orbit or the soft tissue of the palate or soft tissue of the neck. You'll go for MRI. It's preferred. MRI is preferred more for soft tissue. Okay, I think our last questions, we are almost 3 hours or less than 3 hours now. So who's next? Dr. Nawahib or Dr. Ghada again?
A 34 years old woman tripped over
Okay,
and
shall I
fell
go?
into the bonfire whilst intoxicated at a party. She suffered burn to her arm, wrist, and face. They are calculated to be 25% body surface area. She is otherwise stable. The burn to the trough and are superficial. Her left forearm has full thickness burn and the burn to the her face are superficial. There is no airway compromise. She has received 1,000 ml of intravenous Hartmann solution with the further 100 ml prescribed to turn over 4 hours. What should be the next course of action? Undertake an eschorotomy, undertake a debridement and skin grafting, transfer to the original burn unit, intubate and admit to intensive care, discharge home with the daily review. Transfer to the regional burn unit.
Okay, here you have many indications for transfer to a burn unit, more than 20% in adult or 15% in adult, full thickness burn and facial burn also. Even the patient has no problem with the airway, but all these are indication for regional burn unit transfusion. Okay, I think we have here the transfer to burn unit here. Need burn shock resuscitation, face, hand, genitals affected, deep partial thickness or full thickness, burns or significant electrical or chemical burns. All these are important indication for transfer. Even we have another indication here, which is I think one here about the percentage in more than 15% in, I think more than 20%, I can't remember where I did, more than 20% you can refer the patient involving the hand, perineum and face burns. More than 10% in adults or 5% should be transferred to perineum. The last line here, complex burns involving hand, perineum and face, and burn is more than 10% in adult and 5% in children should be transferred to a burn. Okay?
Yes.
Okay, next question, Dr. Ghada.
Okay. A 23-year-old man is stabbed in the right upper quadrant and he's hemodynamically unstable. A laparotomy is performed and the liver has some extensive superficial lacerations and is bleeding profusely. The patient becomes progressively more hemodynamically unstable. What's the best management option? Pack the liver and close the abdomen, occlude the hepatic inflow and with a Pringle maneuver and suture the defect, occlude vascular inflow and resect the most severely affected area anatomically, perform a portosystemic shunt procedure or suture the defect without vascular occlusion. The patient is hemodynamically unstable even after laparotomy. So the first option, because it's damage control surgery, we can pack and then second look, because it's not wise to do a shunt or suturing the defect.
It's unwise to go for anything as the patient hemodynamic unstable.
Yes.
You can't go for anything except for a damage control.
For stabilization first.
Packing the liver, and they go for a second look, maybe using 24 hours exactly.
Yes.
Okay, you can pack this patient. Okay, he's profusely bleeding, but you can go for Pringle's maneuver and start suturing or hepatectomy or something like this. But as the patient is progressively more hemodynamically unstable, so you can't go for any maneuver or you can't go for any further step in the operation unless the patient is hemodynamically better or improving the general condition of the patient. Another last question, maybe Dr. Ali.
Yeah, 52-year-old male present with central chest pain and vomiting. He has drunk bottle of vodka. On examination, there is a small some mild crevitus in the epigastric region. What is the likely diagnosis? Pulmonary embolism, embolus, perforated peptic ulcer, esophageal perforation, myocardial infarct, pneumothorax, chest pain and vomiting after vodka. I'm going with mild crevitus. Yeah, this is perforation. Esophageal perforation, because we have mild crevitus in the gastric region.
Okay. Anyone confused with B?
C.
Anyone confused with B? Because both can happen with vodka, some chest pain or epigastric pain and vomiting. But as Dr. Ali said, crepitus, mild crepitus in the epigastric region, it's a common with esophageal perforation. If it is peptic ulcer, you will not find any crepitus. You'll find abdominal distension, abdominal guarding, rigidity, peritonealism, air under diaphragm if you go for operation, and this is for perforated peptic ulcer. Okay, so for me, first I confuse between both of them, but when I go for crepitus, I went for esophageal perforation. But if the scenario is abdominal pain guarding, even with epigastric pain, vomiting, but you will find maybe abdominal distension, abdominal pain, feverish, guarding, rigidity, toxic patient, acute abdomen patient. So you'll go for perforated peptic ulcer, and both of them are maybe caused by the same cause. I think now we are going to start a new from 1 to 61 out of 61. I think today it's enough, about more than 3 hours. Thank you for your nice discussion and rich discussion today. Thank you for our new participants today. We have many new. I hope you enjoyed our discussion. And I wish the next I'll try within 2 days. I just have some new circumstances in Kuwait. We have curfew for partial, and we started today to be full. And then we are going to have work again, and we stop work for some time. We have just some unstable problems in Kuwait. So I hope within 2 days, maybe tomorrow, if I'm ready tomorrow, I'll continue the questions. I like trauma, and the trauma is very nice and interesting chapter. I like so much, by the way. So if I'm free tomorrow or maximum after tomorrow, we can continue the rest of it. We have about 60 questions out of 90 questions. We just finished 1/3 of the questions this time. Thank you for all, Dr. Tamer, Dr. Moaheb, Dr. Talal, Dr. Iblam, Dr. Mumtaz, Dr. Yasser, Dr. Ahmed Rida, all of you, thank you. And wish you have a good night for those who's now it's too late, I know. And any questions, we are open discussion anytime in the group on Facebook or in our Telegram group. You are welcome anytime to ask or anything. I'll be in help as possible as I can. Thank you for all, and good night, and see you next session.
Good night, and thank you.
Thank you.
Good night, Dr. Ali. Good night for all.
Good night.
Thank you.
Okay.
Thank you, Dr.
Bye-bye. Thank you, Dr. Ibrahim. Thank you.